Hello and welcome. Thank you for your patience during us getting set up with some of the technical side of things. So thanks for bearing with us. My name is Elana Gordon. I'm a reporter and producer at The World, where I cover global health. And this is a Facebook Live Q&A about COVID-19. With me is Dr. Michael Mina, Assistant Professor of Epidemiology at the Harvard T.H. Chan School of Public Health and a core member of the Center for Communicable Disease Dynamics. Hello, Michael.
Hi, happy to be here.
Great. So you all can post your questions for Michael and me on Facebook at Forum HSPH and at PRI The World, or you can email them to the forum at hsph.harvard.edu. And this Q&A is jointly presented by the Forum at the Harvard T.H. Chan School of Public Health and The World from PRX and WGBH. So we are doing this on Zoom, YouTube, and Facebook. Thank you for your patience. And now to get to the discussion. Michael, we've heard over the weekend estimates that 100 to 200,000 Americans could die from the coronavirus, and millions may become infected. It's a lot to take in. And yet we've also heard today about some glimmers, like that social distancing is helping. In one particular hotspot, we're seeing a slowdown in New Orleans, at least we're beginning to, and it might be a little too early to tell fully. But I wanted to start by asking you what these sorts of trends tell you and where you see things as being at right now.
Yeah, I think certainly if we look across the country and really across the globe, I think there's the virus has continued to spread internationally, and of course now it's in the United States and spreading broadly throughout the U.S. And what we're seeing, though, I think that we're going to continue seeing this sort of exponential increase upwards in terms of the numbers of cases that are presenting symptomatically and presenting to the hospitals. And I think it's important to recognize that this was expected. And what we're doing now is all of this social distancing that I think everyone in the United States and globally more or less has become aware of, and that these types of incredible efforts are being undertaken by societies everywhere. What we're seeing and hoping epidemiologically is that this type of true social distancing is going to start bringing that curve back down. But unfortunately, there's going to be a lag. And that lag comes in because a lot of the people who are going to be infected or who are going to present to the hospitals today and over the coming weeks actually got infected before all of this effort to social distance really started. And maybe there was another generation of infections after that in the households, for example. But I do think that the trend, hopefully, it's going to unfortunately continue very steeply up for a couple of weeks, maybe 3 more weeks, and across the whole country, it might be even broader than that. But I think we will start to see some of the payoff of these large social distancing efforts start to be noticeable in the coming weeks.
There's an online question that come in about, why is this virus so hard to track and figure out? And that fits into a question I've just been thinking about that you mentioned about how clinically this plays out in terms of the span or timing, for example, of how the virus presents itself as a disease.
Yeah, so what we're finding is that this virus, it's reinforcing what has been what we've kind of suspected for a long time a long time in this case is just a few months since this virus really emerged in China. But it seems that the virus is actually probably attacking and spreading to a lot of people asymptomatically or with very mild symptoms. And what that means epidemiologically and towards control efforts is that it's just much more difficult to control and contain the viral spread. And this is in contrast, for example, to something like Ebola. Ebola has a very high mortality rate, and symptoms are very noticeable. And so on the one hand, while it's very bad to get Ebola, it's also from an epidemiologic perspective, the containment efforts are maybe not so difficult because you can quickly identify people. With this virus, it seems to be spreading sort of in a more insidious fashion throughout the population, with a lot of people who are getting it not necessarily presenting with any significant symptoms, but then potentially being able to pass it on to somebody who would get very symptomatic. And that creates real burden, real barriers to being able to limit spread without these sort of massive societal changes that we're making, which now essentially in direct response to that problem of not necessarily knowing who's infected, the approach that we kind of have to take as a society is to assume that everyone's infected to a certain extent, and that's kind of why all these policies are starting to be made to sort of shelter in place or not go to work, and that's just to assume that everyone could potentially be acquiring or spreading it, and let's try to prevent that as much as possible.
You've been a big advocate for testing, widespread testing, and I wonder if you still see that as important right now as you talk about assuming everybody has it.
Yeah, I do think that that's important. And I think the reasons for testing change over the course of an epidemic like this. There's a few different stages that an epidemic goes through. The first stage is when it's just emerging and just starting to get into communities. And at that point, there's still hope for containment. And I think we spoke about this the last time we spoke, and probably the time before that as well. And that's that when a new infection enters into a new population, if you can identify those quickly and quarantine and contain them, then you can actually have a glimmer of hope to stop further spread. And so that's where testing is very, very crucial. And every test that you get positive has a major importance. Today, testing is changing. The purpose of testing is, on the one hand, really going towards keeping our healthcare workers safe and keeping their patients safe. But then on the other hand, starting to really think hard about how we'll do wide-scale testing to understand where in the epidemic curve we are, where in this epidemic are we? Are we still at the very beginning? Have very, very few people been infected? And is this going to be something we deal with for years? Or if testing, shows that actually it turns out that 20% of the population has already been infected, that would give us a whole different view than we currently have. And so doing this population-based testing is really going to become increasingly important.
Are there enough tests for that? And what are the limiting factors?
Yeah, so of course, testing has been, it's just been all over the news, and that's because the availability of testing has been restricted severely, and that's because of supply chains and all sorts of issues about how to get the components that go into a test into a laboratory, and then how to even get a sample out of a person and get that to a laboratory. And these things that seem like they should normally be simple become extraordinarily difficult when the basic supply chains start to break down and demand outstrip supply. So I would say that at the moment, supply of tests are certainly growing rapidly, in particular in the United States, where we're starting to see all the big companies start to get their tests on board and into laboratories. But I would say that we still, even with all of this advancement and all of these new tests becoming available, we're still woefully under testing our population. And that's both because of a true lack of tests that are available, but more recently, it's actually been the biggest problem in the last couple of weeks has been how to get the 10-cent swab to put into somebody's nose to get that sample out of somebody and into a test. And that's something that hospitals across the globe are really trying to problem solve around at the moment. because there's a big shortage. And it's an interesting story because one of the reasons for this shortage is that one of the world's leading manufacturers of this particular swab, this nasopharyngeal swab that kind of goes to the almost like that goes a few inches back into your nose. It's made by a company in Lombardy, Italy, called Copan. And this is sort of one of the major companies that produces these. But of course, Italy has been very hard hit by this virus. And so not only are they dealing with extraordinary demand on their manufacturing, but they're also probably out of workers and had to limit manufacturing from a personnel perspective, getting sick. So it shows some of the weaknesses that can occur in global supply chains.
But just very broad interdependence of places and communities. When we spoke last, you had been talked about a workaround when it comes to testing that at least here in Boston that you were working on, and I wonder how that's going.
Yeah, so that has gone exceptionally well, actually. So we in noting that there was going to be a real limitation of what the hospital laboratories could do, because they're first and foremost having to test and provide tests for their patients and their healthcare workers who are in the hospitals. And these laboratories aren't necessarily designed to be doing real high throughput testing. They're designed to have an appropriate facilities for the number of beds they have, for example. And at the same time, then we normally rely on the big companies like Quest and LabCorp and Viracor, these big companies that have national networks of providers that send them samples on a regular basis. And those are normally fine for the normal equilibrium of samples that are sent. But this particular virus, because it's so widespread and this epidemic is so great and the concern is so great, testing has really even overwhelmed these major testing locations. And so what we did here in Boston was we worked to identify what places might be able to pick up some of the slack and help out with testing, but who maybe aren't the most conventional places to do the testing like this. And so myself and a tremendous team of individuals who normally have this amazingly efficient operation to do genetic sequencing at the Broad Institute in Boston. It's an institute that sits between MIT and Harvard. We collaborated and essentially developed a very high throughput pipeline to start testing thousands of samples a day using the robotics that they normally use to do this sort of high throughput genetic screening. And we were able to sort of leverage that and modify the space to be able to handle these types of infectious specimens and reports back to hospitals and the state, and potentially in the near future, things like drive-through clinics.
I'm seeing and hearing and reading a lot about questions about accuracy with different kinds of tests, whether it's 70% accurate or lesser or more. What do you make of that, especially as people are looking for more information?
Yeah, so I think that there's a few different areas where testing accuracy becomes important or where it becomes limited. And in general, I would say that the test itself, meaning that the thing that happens in the laboratory, is not necessarily actually where we lose a lot of sensitivity and accuracy in the test. Where we actually lose sensitivity tends to be more on the sampling process. Mm-hmm. And that could be actually, if you have somebody who's not trained very well to do the nasopharyngeal sampling and they maybe touch the swab to the wrong part inside of the nasopharynx, that could, on the one hand, lead to some reduced sensitivity. But also we're finding with this virus that some people who are sick really have the virus more in their lower respiratory tract rather than the upper respiratory tract where they might be able to get the sample from. And so we're finding that different specimen types and different individuals even have different sensitivities of the test. And then there's a whole different type of test, which so far all the news and all the reports have primarily been about this PCR-based or the detection of the virus itself in people's nose. What we're moving into now, and what I think we'll see over the next few weeks for sure, and definitely into the next couple of months, is a real ramp up of what we call serological tests. And these are tests that look for antibodies that people maybe have made to the virus. And what we see with these tests is these types of tests are notoriously difficult to make and to have them be very accurate. And that's because everyone makes different types of antibodies. Everyone makes, and if you and I would make antibodies that look different, but both can potentially attach to the same virus. So finding the right constellation of things to put into the test to detect our antibodies and make sure that it works for most people in the population is a very difficult task. And we're still working out just how accurate some of these new antibody-based tests will be. And we're trying to improve upon those that aren't yet quite as accurate as we want them to be.
What do you project as like a timeline for that? You said a few weeks or?
Yep. Yeah. So these antibody tests are coming out rapidly, and we're trying to test them. There's a group at the Mass General Hospital here in Boston who's really working on testing like a plethora of them, and then a few other groups that the group that I run, and then as well as a number of other research groups around the Harvard and MIT and Boston University and Tufts campuses are all working on developing these. And I think what we're going to see is that over the next couple of weeks, we're going to see these start to be trialed against patient blood. Now that people have actually had coronavirus, we actually have the samples to test against. And we can say, we know that this person had coronavirus a week ago or 3 weeks ago. Let's take a drop of their blood and see if we can detect the antibodies. And unfortunately, antibody-based testing it can't be used in the same way as viral testing, because antibodies usually become apparent in the blood a week to 3 weeks or so, or even more after the infection. So these types of tests, it's important for people to recognize that if they're being sold as an antibody-based test, it's not necessarily a diagnostic to tell you if you are or are not sick at that moment or with virus. It's really to help you understand if you've been exposed to the virus in the past, maybe near past, a week or two ago, or potentially even years ago. And we do things like checking for measles antibody titers, measles antibodies to know, did somebody get a vaccine 30 or 40 years ago?
This question comes from Miranda. Why can't you use Q-tips for swabs?
Yeah, so the short answer is that using these natural fibers like cotton, and the wood shaft on Q-tips is often wood or something else that's kind of based in something wood form, is there's little proteins, little molecules in these natural fibers that can sometimes cause the test itself to not work appropriately. The test, I won't go too technical here, but the test has these little things called polymerase, and that helps the test run. And these are little molecules that are actually initially came from bacteria years ago, and they were figured out how to hijack them to use for molecular tools in the laboratory. But unfortunately, natural products like cotton and wood can deactivate those polymerase and cause it to not work so well.
This question comes from Tiffany, but I want to combine it with another online question too, which is just getting back to the supply chain. When you look at tests, why has it been so difficult for the US compared to other places? Why has the US not been as successful in gearing up testing? And the other question has to do with personal protective equipment and where some of the weaknesses are in that supply chain when it comes to the US and globally.
Mm-hmm. Yeah, so the observation that the US isn't doing so well with testing is absolutely correct. In part, that's because we have just the sheer size of our country means that the number of tests we need per populace is very, very high to keep up with some of these other countries that are much smaller. And the number of labs we have, while it's more than other countries, I don't think that it is per populace, the number of laboratories that we have to run these tests is not necessarily, does not necessarily scale linearly with our population. So we're kind of at a disadvantage in that sense. But I think one of the real major reasons, because we have plenty of technology in this country, I think that one of the major problems that I see is that we have no way to centralize things in this country, short of declaring martial law and giving a tremendous amount of power to the federal government, which is obviously something that this country is not used to, nor desires for the most part, I think. And so what that means is that there's little ability for a central sort of command unit to pool all of the resources from around the country. And you don't have any one major big warehouse lab type of thing that can say, okay, Wisconsin, Ohio, New York, and Pennsylvania, everyone send their supplies and their equipment here and really bank on economy of scale. We don't really have an ability to do that. We're very fragmented. And so what that means is that every lab that has tried to get this test up and running has kind of had to start from scratch in a way and sort of do it on their own. Now there's a little bit more help now that some of the more manufactured testing, true test kits are coming out from like Roche and Hologic. Those are making it easier and decreasing the barrier to entry for a lab to get the test running. But there was no major ability to scale and pool resources across the population. And that's something that I think differs in places like South Korea or China, where they're able to really draw people, both resources, manufactured resources, but also people resources into centralized locations and really create massive organized efforts to use the economy of scale there. And I think our individualized sort of healthcare system and laboratory system, and even the way we pay for healthcare in this country is so fragmented that it makes any sense of doing this in a coordinated fashion across major sort of landscapes very, very difficult. And then I think you asked about the masks, is that right? What
personal protective gear, but I actually just on that question, and this could fit into it, this question that actually answers another online question, but Kristen also asks, the federal government has talked about the supplies and making that more available. So how can they do that and get those things distributed? Or is what you're talking about just the nature of how things are set up in the United States and how healthcare works?
Yeah, as we can see, it's taking a long time now for the federal government to react in a way that could get them to a place where they can say, okay, we're going to really start pushing manufacturing plants to make more personal protective equipment, for example. I think that it's the fact that it's taking a long time for them to get to that point to be able to make these kinds of efforts to really sort of cajole manufacturers into doing this, when maybe it's a product that these manufacturers don't normally produce, so they have to create plans. I think, but in general, had there been, if we were a different type of society, one that had that, where there was sort of more a quicker ability to sort of rapidly respond and deploy and sort of direct different companies maybe to sort of divert some of their efforts into more into making personal protective equipment for the good of the community. I think that type of oversight would have been beneficial here, and it's just not something we have. The way that the government's doing it now is, I think, really trying to, through economic stimuli, and trying to still work within the framework of having companies and corporations be separate from government, but hopefully having the government work very closely with partners in industry to make this move forward.
Where do you see, then going back to the personal protective equipment, as we're talking about medical supply chains, some of the weaknesses in that aspect?
Yeah, so I think what we're seeing is the world generally has, we do keep a national stockpile of some of these things like masks and personal protective equipment. And I think most of the way that a lot of the ways that we've been thinking about things like a national stockpile, I think have more to do with this fear of bioterrorism and threats and sort of short-term events that might require these types of pieces of equipment, versus really having a national stockpile and pipeline to ramp things up in terms of production, with the thought that a major pandemic that goes on for a long time could that they would be needed for that. And so the stockpile that we had, while large, is clearly insufficient to provide supplies to the entire nation on a continual basis for, for potentially months and or more. And so I think that that's where we kind of are. And what this is really demonstrating is that from a preparedness position, we don't have the type of manufacturing operation sort of sitting idly by to really ramp up production of these types of necessary pieces of equipment, whether in this case, and part of it's because we never know what will be needed. Masks and gowns are pretty good bets. Those are general things that we need for controlling infection in healthcare facilities. But things like ventilators, those are in short supply now. And I don't know that we would normally have kept a national stockpile of ventilators. It's just not something that probably has come across the desk of many people making those decisions, I think.
So places are now just kind of looking for their own supplies outside of that, whether it's globally or within communities.
Yeah, and we've seen an outpouring of support and desire to help from our overall communities. Meaning in the academic sphere and the academic hospitals, our research communities have tried to step up and say, here's all of our protective equipment that we have from the labs. Generally, those can last just a few days, really. Like you could take all the laboratory personal protective equipment that exists in the Harvard ecosystem and give it to the hospitals. And at the rate we're burning through it in the hospitals to treat patients, we're finding that it just doesn't last very long. But then we're also seeing pretty impressive efforts. Just personally, I've seen a number of people who have gone so far out of their way to help. A lot of people, for example, who have family or are originally from China or have family in China, have really stepped up to say, hey, I have connections in my family has connections who have connections to this plant that can potentially manufacture a lot of swabs or a lot of masks. I can put you in touch with them. How many do you need? And these types of like very far removed connections that are being made through just the goodwill of sometimes just people out in the community writing emails has actually made a big change. And we're getting thousands and thousands of swabs now because of some of these individuals who have just helped to make these connections, and in some cases are even purchasing them on their own and donating them to the hospital. So it's been really, really impressive. And that's just in my own little orbit ecosystem here. I'm sure the efforts everywhere are enormous.
That's surprising to hear you describe it that way. And it speaks to this question that's come from many people like Rebecca and Kristen, who had asked, what can regular citizens do to help? I wonder if there's anything you wanted to add to that.
Yeah, I think that those types of efforts are extraordinary, and they require those kinds of connections. But we're seeing, in particular, in places where supplies are really, really very, very limited. We're seeing people stepping up to make masks, and these masks won't be perfect, but we know that if somebody's symptomatic and they need to leave their house, for example, they will help. And some of them are just fabric masks that are being sewn in somebody's basement. And these are some other extraordinary steps that people are taking to really help. I think the major thing that the average person in the United States can do at the moment is to try to not infect other people and try to not get themselves infected. And that action of being willing to stay at home for the moment goes tremendously far to help prevent and protect everyone. And it can be an extraordinarily burdensome action. Sounds strange because staying home is usually nice, but after a while it will get tough for people. But the important thing to remember is you're not just preventing yourself going out if you are a young person and you worry that maybe you won't get sick and you're fine to go out. I think we have to remember that if you do go out and you get sick and you pass it to somebody else who then has to go into the hospital, the hospital still needs to run and do their normal things as well. So actually by the community getting sick, it sort of puts everyone at a level of excess risk because the normal healthcare won't be around. So all of that said, I think the major thing that most people can do is really just try to participate in the removal of transmission chains from our population. It's absolutely critical right now. And over the next couple of months, it will be even more critical to keep sort of remaining in place, if you will, even when things start to calm down so that it doesn't flare up again. And then policymakers and public health experts and others are working day and night right now to figure out what's the real next step forward.
So I want to combine two questions and throw them at you. One is from Barbara and one is from Amanda. But it speaks to similar things. Barbara asks, has a voluntary or required reporting system to track the delivery and receipt of these kinds of supplies been set up in commercial suppliers? And the question from Amanda is like, how does someone find the best estimates of the number of critical supplies that are projected to be needed in the US? It sounds like these both come from like planning perspectives and policy, supply types of aspects.
Yeah, so there's, I would say that there's not at the moment, there's an effort to create more of a national database of what's needed and what exists, but it's very, and this comes back to my point before, that things are so fragmented in this environment. Just getting the hospitals within given cities to coordinate has been a tremendous feat, and one that is probably not taking place everywhere, but hopefully starting to. And then at the state level, these things have to be coordinated. I know in Massachusetts, we've had a tremendous effort by Governor Baker and congressmen and senators who are in this state to try to help coordinate these efforts and put committees together to really talk to each other. And so I think piecemeal, in a way, state by state, county by county, these databases are being constructed, but there has not been any clear sort of major database that people can just kind of log into and say, okay, what's needed? But I think that the efforts are starting to be grassroots built, and we're starting to see some websites pop up, for example, for people to donate or for other people to sort of write what they need. And these types of things are happening, and maybe even at the national level over the coming weeks, we might see that happen as well.
I want to put out, if you have some time, just for a few more questions. One is from Al, and it goes back to what you're talking about with social distancing and what each individual can do right now in terms of preventing the spread. But one question is, as these measures kind of drag transmission away from the general population, what can be done within households to prevent the spread?
Yeah, so within a household, to be honest, it is difficult. Now, if there's somebody who knows that they're sick, then certainly trying, and in particular, if there's an elderly person in the household and a younger person might be sick, I would suggest trying to think very, very hard about how maybe to move that older individual or vulnerable person out of the house while the individual is sick in some way. And because it is going to be very, very difficult within the living quarters to prevent spread. There can be extreme steps that are taken, but they will be miserable, which are things like having somebody just stay in one small section of the house during the time that they're sick. I think for that purpose, and I don't know that my voice should be the only one that's heard on this, because I think some people might disagree. But I think for especially for younger individuals, we will not see that the majority of them will have severe disease. So sort of like if your 15-year-old has coronavirus, I wouldn't suggest locking them in their room for 2 weeks. I think that the trauma associated with that, it could outweigh the harm of some other young, robust people getting sick. But certainly if there are elderly people in the home or other people who are immune compromised or otherwise vulnerable, I would think hard about how to maybe separate the two entirely and to get them into different living spaces that are appropriate.
This question comes from small MB1. Is it really possible to sanitize N95 masks and other PPE and reuse them several times?
Yes. So sorry, let me go back to that other question, because I didn't really answer the question. And I do want to point out that you should still aim to prevent transmission within the house. So washing your hands, like things like scrubbing down surfaces a lot with things like Lysol and washing your hands. These things are absolutely crucial. Will they definitely work to prevent, you spreading an infection to your partner, for example, or spouse? I don't know. That does seem very difficult if you're living together. but certainly trying to be as hygienic as possible if you are sick to try to prevent others, especially during the week that you're symptomatic, for example, I think is very important.
Thank you for clarifying that.
Sure. The N95 question is a good one. And we are working on it. There are people who are doing it, and I think that these masks can be sanitized through things like ozone and different gas sanitization processes. And there's research groups working on it right now, some in Boston and everywhere in the world. Groups are trying to figure out just how to sanitize a mask appropriately to ensure that that it is decontaminated after a while. The most simple, you know, if you're in a very highly under-resourced setting in sub-Saharan Africa, for example, and you have a very limited number of masks, and you maybe have enough to be able to cycle through, the most basic way to potentially kill off the virus on them, if it's there, is just to have a stock that you kind of cycle and you let them sit, you know, for a couple of weeks and then reuse it after it's been, you know, 2 or 3 weeks, because we believe that the virus generally dies after 10, 15 days entirely. And so that would be one way. The other way is to use more like chemicals and do different sort of sanitation procedures that can be done maybe in more of a laboratory type of setting or in a hospital type of setting.
I want to give you a moment. We just have just a minute left to just kind of wrap up with some concluding thoughts on kind of what you've learned, what you still need to know. We talked about it in the beginning, but just kind of the things that we know right now, I wanted to just see if you would wrap up and provide some kind of useful information for us as we're trying to navigate this.
Sure. I think the biggest questions that are on people's minds are, how long is this going to last? And that's one question. And I think the short answer is, unfortunately, that we're not sure. But we do think that with good social distancing measures put in place right now, we can anticipate that the major boom of this epidemic, we're in the thick of it, and it's going to continue increasing and increasing for a couple more weeks, maybe 3 weeks, maybe 4 weeks in some places where they got a late start to social distancing. But then things will come down. And I think that's important to recognize that throughout the month of April, it will look really bad. People might get discouraged because they'll keep hearing on the news or seeing for themselves, unfortunately, that hospitals will continue becoming more burdened, and they'll potentially start to question why the social distancing is happening if it's not really working. But I think the important thing is to remember that there is this anticipated delay, and throughout the month of May, I think we can anticipate to see the number of cases really fall off. And going into June, we'll start to see that hopefully there will be very few cases into June. That might be benefited by the weather. We still don't know just how much the warmer months are going to help. We know that a lot of times respiratory viruses like coronaviruses don't transmit as much in the summertime. We don't know the exact mechanism for that, so it's hard to say right now if that's going to be the case here. But we hope. And then we have to really, as a society, work on the long-term plan, which is sort of how are we getting the economy back to work and the society back to work and running. And that, I think, is going to take some real coordinated public health effort, and we'll see that coming on board. There's some other questions, like when are therapies coming around? Do we have any antivirals? And there's been a lot of talk about chloroquine and some other antiviral drugs. And I think those trials are going on right now. There are some drugs that are being repurposed as an antiviral from other infections that are looking fairly promising. The question surrounding chloroquine, I would say, is unknown at this point in time, and there is a real need to study it to better understanding if it's going to be beneficial at all. And then vaccines are, I think they're still quite a ways away. And 12 months, 18 months, those are good estimates if they work. And what we're finding, what we hope is that they will work biologically to protect people, but we'll have to determine if they actually do work. And and there's a chance that we could get to 12 months and get through phase 3 trials, show that they're safe, but then find that they're not effective. And we want to just have a bit of caution when we pin all of our hopes on a vaccine. These are very, very difficult vaccines to make, and so that's not to end on a doomy point, but I do think we have to keep that in perspective. On a positive point, I think the testing is becoming more and more readily available. I think people should keep an eye out for these antibody-based tests. People should also, I think, before ordering them, if they become direct-to-consumer products, some of them might be scams, and I think we have to keep an eye on our companies creating scams, and so people should do their due diligence, read about it before they order these, once they become sort of direct-to-consumer. But they will be available in the coming weeks or months, and this will help us really understand this epidemic and help people know their status of whether they have or have not been infected in the past.
Michael, thank you so much for your time.
Absolutely. Very happy to be here. So many more questions are coming in, but we will wrap that up for now and conclude this Facebook discussion. Thank you again, and to everyone for your questions. This Q&A is jointly presented by the Forum, the Harvard T.H. Chan School of Public Health, and the World at PRX and WGBH. You can view the full discussion on our Facebook pages and send feedback at Forum HSPH and at PRI the World. And you can join us again next week, Tuesday, April 7th at noon, when we will be talking with Leonard Marcus, who is the founding co-director of the National Preparedness Leadership Institute. And we're going to talk about crisis leadership. So thank you, and let's keep the conversation going.